To the Black Health Perspective, where we'll talk about our health from our perspective. I'm your host, Millicent Duncan.
And I'm the co-host, Brian Duncan.
Episode 5.
Episode number 5.
I'm excited.
Rolling along.
I am excited. I'm super excited today. So today I have with us Miss Anne Allen Westbrook. She is a native of Savannah, Georgia. She's a graduate of Savannah Christian Academy. She went later on to receive an undergraduate degree from Hollins College, correct?
That's correct. Mm-hmm.
And she's also received a JD degree from the University of Georgia School of Law.
All right.
With that, she has a distinguished career as a lawyer, an advocate, and a legislative aide. And now she's running for House District 163.
That's right.
Did I leave anything out?
Nope, you definitely hit the important points. So thanks so much for having me on.
Well, thank you.
We are really honored to have you, and we look forward to this conversation for the next little while.
Yes.
And hopefully we can put some good information out there. I know we can.
Yes.
I know we will. So thank you again for your help. We appreciate it.
So I think what I want to first ask you is what made you become interested in running for House District 163?
That's a good question. Because I am not, my studies were in political science and law. So I've definitely always been a person who was interested in law and policy and a believer in the potential of good policy and good laws to lift up people's lives and to make our lives better. So that background is always there. But I was not a person who was like, well, when I'm 25, I'm going to run for, whatever, and then I'll climb the ladder. I did not see a political career for myself at all until I was in my 40s. And by that time, I got involved in the gun violence prevention movement with a group called Moms Demand Action for Gun Sense in America. And which I think is relevant to what we're talking about tonight, because that group very much takes a public health approach to gun violence. So it's not just an issue of crime. It's not just an issue of law and order. It's an issue of so many things, but one of those being public health, and that's a public health crisis. So in the course of that work, I coordinated volunteer advocacy efforts around that issue with a real focus on the Georgia General Assembly, so our state legislature. And through the course of doing that work, I think I was like a lot of people. I was, building my career. I was raising my family. I have 3 boys. I was just sort of trusting that our leaders they have this. And through the course of that volunteer work, I really came to see that there's a big disconnect between our leadership in Atlanta on that particular issue. And just the everyday folks I know, my neighbors, my friends, my family members, and sort of like what those folks are looking for from their leadership was just not really what's coming out of Atlanta on the issue of gun violence prevention. And of course, once you get involved in one issue, you start watching all the other issues. And so that's what led me to decide to do it. So when my state house seat became open, I decided to go for it, despite not really having it in my life plan to run for office.
Okay. All righty.
Well, it takes a lot to take that big leap, and we certainly wish you the best. And again, we appreciate you coming on and try to put out a little information for our listeners and our viewers.
Okay. So we're going to jump right. Well, the reason why we're asking you to come on our show today is to discuss Medicaid expansion. So Georgia is one of, I believe, 12 states that has, as of yet, to expand Medicaid expansion. Can we discuss what Medicaid expansion would mean for this? Well, let me go over some things that I have researched. Like currently, there are like 1.4 million Georgians who are without health insurance in the state of Georgia. But with Medicaid expansion, there's this gap. if make sure I'm understanding it, I want to make sure I'm understanding it correctly. There's this gap of individuals who would make, is it above the poverty line, right above the poverty line, but yet, let me make sure I look at it correctly. They would make above the poverty line, but yet they don't make enough of subsidies to receive subsidy assistance for insurance benefits. Have I explained that correctly?
I think you have. I think it's useful if you don't mind to back it up a little bit, and I'll bring my electoral politics knowledge and my policy
Please
hat.
do, yes.
Take the lead for me on that, because
sure, I'll kind of fill in that background a little bit as I understand it. You know, we as Americans, we have a system that's fairly unique with the rest of the developed, you know, as compared to the, you know, a lot of like high wealth nations like Europe, like Canada, like so many other places. You know, and that we don't have, for the most part, socialized medicine. We don't have single payer. We have an employer-based system for health insurance. And there are folks for whom that works really well, especially people who work for large employers that can, you know, sort of bring those costs down to when you cover a large group of people. So this has been our history. This, you know, politically, this is something we've been looking at certainly through a lot of the 20th century. And so if we kind of go back to early in the administration of President Barack Obama, this was something he really wanted to tackle. And I don't know y'all's age, but I'm old enough to remember the 90s during the Clinton administration when they tried to look at this too. And it was a big...
Yes, so that's, if I'm not, because we're around the same age, and I think what they were able to pass during that time is when Hillary was able to pass is peach care for kids.
Right. That was at the state level, but yes.
Right.
So, you know, early in the President Obama administration, he really made this his central policy objective. And early in his administration, the Affordable Care Act was passed, sometimes known as Obamacare. And so that was designed just to cover more people, basically, because we all know people who are uninsured, who are underinsured. You know, to kind of touch on the pocketbook issue piece of this is one of the largest drivers of personal bankruptcy for Americans, is an unplanned for health emergency. So early in his administration, the Affordable Care Act was passed. And the way that was designed to work at the state level was Medicaid expansion, that term that we're talking about. And so it was going to extend coverage under the Medicaid program to people at, I want to say 138% of the poverty level.
Right.
Okay. And what that would do is that would pour federal dollars into the states to help with the cost of that, something like 90% of the cost.
Right.
But politics being what it is, there were a lot of states that were really, really resistant to that. And it tended to be quote unquote red states like Georgia, like most of the sort of Southeast, you know, parts of the Midwest. And so the poorer citizens of those states, or people, you know, with specific circumstances, just couldn't get covered. And so that's kind of, I think that's one important thing to remember, is this is really how the ACA was designed to work, was for these policies to take place at the state level. So that's kind of how long we've been talking about this. I mean, the year that I have in mind, I want to say is 2010, as I kind of feel like when we were really having a lot of the debates around this.
Yes, because he came elected in 2008.
Right. And that was right about the midterms.
Yes.
Yes, exactly. So that's how long we've been talking about this. And it's become really political. And you know, states like Georgia that have, and we're not going to get real partisan today. I don't think that's the point of our podcast.
No.
But it did sort of become political, and there was real resistance on sort of a partisan level to this idea. When a lot of it was an idea that had sort of sort of been birthed in conservative think tanks, and some states with Republican legislatures had passed it. So it really just became, there's been resistance to this idea for a long time, until we're almost like, okay, wait, why are we against this again?
Right.
So I think that's kind of worth mentioning.
So I guess, one of my questions one of the first questions that I asked, it says that 240,000 Georgians make too little to receive financial help to buy private health insurance, but do not qualify for Medicaid.
Mm-hmm.
So what my question is what my concern is, as we are seeing a wage increase for individuals, it's no longer the $7.25 that they're now, you're seeing signs that they're making between 11 or even higher than that. Does that take individuals who now qualify for Medicaid and placing them at a risk of no longer being eligible for Medicaid? Am I making sense with that question?
You are, and I think that risk is very much there. And this is sort of where the COVID-19 pandemic, I think we need to at least mention that, which is for two reasons. During the pandemic, basically the federal government sort of did a freeze on anybody who was currently enrolled in Medicaid getting kicked off of Medicaid. Normally, there would be periodic reevaluations. Has your income gone up? Has something about your circumstances changed so that you no longer qualify? And because the pandemic was, a global pandemic, that affected people's health, that affected people's jobs, the federal government just sort of froze that. But that's coming to an end. And so when it does, those things are going to be reevaluated. We also are in the midst of a labor shortage. And so it's not surprising that wages are going up, and they, I think I would argue they need to go up, especially, right. There are places where there's a real shortfall between what people make in wages and what it costs to live in those places. We see that here in Savannah, Chatham. So I think those two things come into it. But yeah, I think there are going to be people who qualify right now, who are at risk of not qualifying, and certainly our coverage gap population, I think, could grow.
Okay.
Yeah.
So I see, as I was reading, I see that Georgia has they attempted to do a partial Medicaid expansion, with some caveats that deterred from what Medicaid and Medicare services. And I do apologize for our dog if you hear her.
Oh, that's quite all right. Mine will probably jump in my lap at some point. So.
Okay. But we see that CMS has halted or has formally withdrew their request to allow that partial Medicaid expansion. Can you give us some enlightenment as to what that partial Medicaid expansion was, and why? Why are they requiring what are their concerns behind requiring a work requirement, and why does our legislative branch do not want to increase to the 138% of the poverty level? What are some of the concerns that they have for not agreeing to the full terms of Medicaid expansion?
Well, this partial Medicaid expansion idea is really it's an alternative idea. It's called a Section 1115 waiver, and so you can apply. You're, as a state of Georgia, we can apply to that federal department to say, we've got this alternative program. It's designed to sort of meet the same needs as the Medicaid expansion. Will you give us a waiver? Mm-hmm. And again, this is kind of where politics has come into it a little bit. I think over the course of the Trump administration, some of again, you had, a different party was sort of in charge of some of these departments. And so some of those waivers were going through. And, but when Georgia, made its application, the department at CMS, and I'm spacing on what that's short for. It'll come to me in a minute.
For Medicare and Medicaid services.
There you go. Okay. So CMS denied it. as I understand it, for two reasons under the Georgia waiver program, which is called Georgia Pathways to Coverage. It has a work requirement, an 80-hour-a-week work requirement. So that's either work or that's some sort of like volunteering or schooling, some sort of community engagement. And then also we have premiums in Georgia associated with that program. And so the two reasons, as I understand it, that CMS kicked it back were the work requirement. And a lot of states have put those work requirements on. Some of them have gone up to the courts and been kicked back. Ours is currently in litigation because when CMS kicked ours back, the Georgia program, it did so on the basis of the work requirement and the premiums. And basically, the state of Georgia is now suing to see if we can keep our program as it is. But yeah, it is a lower threshold than the 138%. But I think the two big things of why it was rejected were the work requirement and the premiums.
So Georgia was going to require that the individual still pay premiums. Do you know the amount that they were requesting that they pay in premiums?
It's a sliding scale, and I believe it is capped. Let's see. Beneficiaries with incomes between 50 and 84% of the federal poverty level will pay a monthly premium of $7.
Mm-hmm.
So, to you and me, that seems pretty low. But again, folks at the federal poverty level are hovering around that. That's going to be, that could be more of a barrier. Yeah, I mean, there could be more, more cost associated with being a tobacco user. That's not that unusual in, sort of in healthcare generally, because that does drive up costs. But it's not supposed to exceed 2% of household income. So that's what the cap is supposed to be. Okay. So yeah, that was part of it.
Okay. And so currently Georgia has missed out on like $21 billion in federal healthcare dollars. Let's talk about what areas that we could have used that $21 billion, because they have elected to not expand Medicaid in Georgia. Some of the shortfalls that we have experienced, like we know that there's how many rural hospitals have closed since we have elected not to expand Medicaid.
I want to say it's 7. Yeah, 7 is the number that's sticking in my mind. Mm-hmm.
We have had an incline in mental health.
Right.
Do we know because like I said, I can only go from the experience that I have working in the emergency department and see how our halls are filled with individuals with mental health crisis, and that there is a lack of beds to have these individuals adequately placed to receive the treatment that they need. And you can always hear the conversation of in regard to what insurance they have, and if they have no insurance, the wait that they have to wait for bed availability. What are some areas that we could, other than mental health, we could have improved? Substance use disorders, or substance abuse disorders treatment centers, and so forth. But what other areas could we have improved those federal dollars? Because we save the money that we could have received from the federal government, but how can it have been applied to our communities so that people can see it more in dollars and cents?
I mean, to me, the first thing for me is that we need to talk about maternal mortality in Georgia, because Georgia has very, very high rates of maternal mortality. Approximately a third of our population in Georgia is African American, and Black women in particular are anywhere from 2 to 4 times more likely to die than white women. And so to me, that's just unconscionable, because if we aren't looking out for mothers, what are we doing? And so I feel like we have to talk about that. If for Black women, this is about the worst state in the country to have a baby. And so that's not, we tend to think about this in terms of, catastrophic events that happen, in labor and delivery. But when we talk about maternal mortality, we're really talking about that whole 1 year postpartum period. And I think at least some of what we need to be looking at is, long-term chronic underinvestment in healthcare. And so, women have babies every day. But when you have underlying health issues, that becomes a more dangerous prospect than just sort of like the normal health event that it should be for women. In a country like the United States, where we are an extremely high wealth country, we have the ability to do this. We just aren't. And I think that's a policy decision we really need to look at.
So you spoke on the fact of mortality rate 1 year postpartum.
Yes.
So that would align with individuals who have a child at 6 weeks, but they're returning to work at 3 weeks. Because I remember as a college student returning to class at 3 weeks. And but then you see those, once I became a nurse, and see those individuals coming back into the hospital because that is their immediate or closest, their most closest, help me say it.
That's where they're entering the healthcare
yes,
system.
That's what, yes, that's the most efficient way for them to get in, get out, and get back to work. Does that make sense?
It makes perfect sense. And that kind of gets back to the original point of the Affordable Care Act, which was too many Americans' experience of healthcare. It wasn't going to see that primary doctor, on a regular basis. It wasn't all those well visits and all of those things. It was wait until you get sick and then present to the emergency room. And that's not the way to do. I mean, y'all are the healthcare professionals. This is your subject matter expertise. But from everything I understand, that's not the way to deliver the best.
No, because you can't. You see so many people come to the ER because this is their only resource. And as I said in one of our first podcasts, in the ER, we only have a nugget of time to give you the education you need to follow up. And it is a good day if if that nurse that you are assigned knows the resources that are out there. It's not as if it's their fault. It is that we are taking care of 1,000,001 things. And then with my husband, him being a paramedic and in the field, he can come and pick you up from your home 50 times, but that does not mean he has the knowledge or accessibility to know where you need to go at in the community to follow up.
Right. Yeah, that's really care that when you're in some sort of crisis, there's something emergency room going on. But like these bodies that we all have need care day in and day out.
Correct.
And so when people are only going to the emergency room rather than seeing those primary care doctors and whatever specialists they need, they're just not getting the health care they need. It's, we also should say that's a very expensive way to get health care.
And it can lead them to, like you said, it's the number one I'm getting tongue tied because I think
cause of bankruptcy. Yeah.
Yes.
So what do you do when you're in that situation? You think, do I really need to go? Maybe I could wait this out. Maybe I'll just lie down and see how I feel tomorrow. That's kind of, it leads to that, underinvestment is sort of the word that I think of when it's a large population, but on an individual basis, it leads you to delay care, to not seek care, and that's just.
I think ultimately too, that will increase medical costs, because if you wait till till a devastating event happens, as opposed to getting treatment and follow up initially, you could have a more catastrophic event, which leads to higher costs in the long run.
Absolutely.
But you have to also understand, if I'm a single mother and I have to go to work and the rent is dependent upon me working,
There's so many factors.
Yeah, because I often would look at some of the individuals in our hospital who I worked with, our ancillary staff or so forth. And I realized how much it cost us we were fortunate to be under TRICARE for our health benefits.
Mm-hmm.
And to think about the cost there, the monthly cost at the hospital. And I'm like, they can't afford this, so what would they do if they experienced a health crisis?
Yeah, they just probably delay it or really
elect not to receive health insurance to do their job.
Exactly. And I think that's, even for those of us who, we have health insurance, we have access to it. Maybe we have a high deductible plan. That's a lot of businesses. We're still you still sort of do that bargaining. Do I really need this $1,000 MRI that my doctor says I need? You get into those kinds of decisions. And so when you're sort of at the lower end of the income spectrum, it really does become a difference of, what am I giving up?
Yes.
Do we get groceries this week? Do we cut back on groceries? Do we delay paying that electricity bill? What if they cut, these really kind of, serious decisions.
I worked for the Department of Veteran Affairs. We're just going to continue on Zoom. I worked for the Department of Veteran Affairs for 5 years, and I did case management. And a lot of the time, a lot of time when organizing that care with our veterans, it was that negotiating care and housing.
Yes.
That negotiation. Do you know what the average premium is currently for Georgians in Georgia?
I don't know that. I don't know the answer to that.
Okay, that's fine. Yeah.
I was looking at that I did look into the national.
Okay.
And the national average unsubsidized premium for a 40-year-old non-smoker was $436 per month, for anywhere from $436 for sort of a higher quality plan, down to $328 for a somewhat lower quality plan. So that ends up being, a pretty significant percentage of someone's income if you're at the lower end of the income spectrum.
Wow.
But there was one other thing I kind of wanted to talk about that I think is somewhat analogous to this issue is, well, COVID. I mean, we're not even out of it yet. But I think we also saw in Georgia, again, who was hit hardest by COVID, and it was, populations. It was the African American population, it was the rural population. So, folks who, again, sort of long-term, underinvestment into healthcare of those folks.
And those individuals are typically your frontline workers, such as your cashiers, the ones who needed to continue to work during the brunt of the pandemic.
Absolutely.
Your individuals who were independent contractors who still needed to provide a source of income for their family.
Right. And as you say, the essential jobs, jobs that somebody had to keep those grocery stores open, all those kinds of things. Not everybody has a job where they can say, well, I'll just work from home on my laptop. I've got my email, I've got my smartphone, that's how work works for a lot of people, but it's not how work works for everybody. So, that was definitely some of it. And there's sort of a whole other conversation we could have about racial disparities in healthcare too. And so when we have a population in Georgia that is 1/3 African American, that's a lot of people potentially experiencing racial disparities. This isn't my experience, as I sit here, but we know that racial disparities in healthcare are a thing. When Serena Williams presents to her, says, I experienced disparities as a pregnant woman, we know that we are not talking about socioeconomic status when we're talking about Serena Williams. That's just a straight up racial disparity.
Correct.
Mhm.
And I can say personally, yes, 20 years of working in the ER, I have some great coworkers. I have. But I think that there are just some things that other individuals cannot visualize in the same manner that I can,
Right.
or other Black nurses can.
Yeah.
And I just have to be honest when I say that, you know, when you culturally, family dynamics, because either I have personally lived them, and so to understand this family that maybe the grandmother is caring for grandchildren, and you know, it's so, yes, we see those racial disparities and on so many occasions in that setting. And I have stood up on several occasions to point them out, but I don't know if your counterparts are really able to look at it through that lens, because they have not experienced it on that other side of the camera. Does that make sense?
It makes perfect sense. I mean, I think it's an argument for why we, you know, it seems like this is a conversation to bring our medical schools in Georgia into, like, how are we training the next generation of Black doctors?
Mm-hmm.
You know, how are we keeping them in our state? How are we keeping that talent here? Because what you're saying, and I've heard it from other people too, is, you know, you can sort of share that perspective in a way that a healthcare provider of another race might not be able to.
And it's not to say that they're not empathetic to it. It's just that
it's not their experience.
It's not their experience. It's not when that patient will call from you across an ER to come and explain something to them, and for them to feel like they're being ignored. And also with us having so many past disparities and stories that are passed down from generation to generation that are told to you, you walk in the door with mistrust. I will tell you that. You walk in the door with mistrust. As unfortunate as it is, you do. You walk in the door with mistrust, and so every move that is made, you're looking for that guiding light of someone that you know.
Mm-hmm.
And so the first Black nurse or Black doctor that you know, you call out to them. And I like to be that individual that can offer them some assistance, but you can't be there for everyone.
Right. Yeah, absolutely. I mean, I think that, like, you know, this is just one part of, you know, a broader conversation about implicit bias. I mean, we know that very well-meaning people can have implicit bias. It's something, you know, that people like me have to work on or make sure that we're at least thinking about it. We're sort of trying to arrest those biases when we find them, but like, that's kind of what implicit bias is by definition. It's not a malicious intent. It's just a failure to, you know, to see, to understand, to, you know, relate.
You know,
and I think it's also worth saying in this conversation about barriers to care, that becomes a barrier to care. Right. So it just feeds into this larger conversation, I think.
So yeah, it's a barrier to care because individuals are already mistrusting coming in the door. They do not feel as they're not receiving the same information, or they're not receiving all needed information going out the door to make sure that they have accessibility to resources that are available to them in the community. And so,
yeah, I think that along those lines, you know, they just kind of feel like they're being left out. You know, they come in, they get it's a quick fix, and they're gone with no real guidance as to how to keep from coming back again in the future. You know, these resources that the state has passed on would probably be beneficial to a great many people, in terms of putting out that information, letting them know what those resources are, and perhaps just having a little bit better outcome.
But expanding, because I know we have to end right quick, expanding Medicaid would offer us the opportunity to open more communities, resource clinics, would that allow more private paying, more physicians to be willing to take Medicaid-based insurance, because a lot of physicians are not even accepting Medicaid as a payment source.
I think it would just, as I understand it, would just become a larger share of the market. So it would be harder for them to do that. I mean, but in its most general terms, what I understand Medicaid to do is to cover more people at lower cost. And, certainly when you compare it to, those Medicaid waiver programs. And the other thing to remember, and I know we need to end soon, is, we as Georgians, we pay into those funds we pay federal taxes too. So instead of sending those tax dollars we've paid off to states that expand Medicaid, why would we not bring them back to Georgia to cover our population, to make a healthier population, to boost people financially as well, so that they don't have this burden.
All right. We'd like to thank Ms. Anne Allen Westbrook for being with us this evening and bringing us her perspective on Medicaid expansion here in Georgia.
Episode 5.
5 is in the books.
5 in the books. I want to thank everyone for being patient with us, tuning in each week as we continue to have conversations and discussions on topics that are important to the Black community. Again, our health from our perspective. So as always, we ask you to like, follow, and share. We can be found on YouTube, Instagram, and all podcasting platforms. Join us again in 2 weeks.
2 weeks.
July 17th, as we continue our conversations. And again, thank you for tuning in to the Black Health Perspective.